This presentation is going to talk you through Purpose T. We're going to look at assessment tools, the benefits and limitations of Purpose T and other limitations of other tools, how Purpose T was developed and the main differences to this compared to Braden as a tool, Purpose T step by step and the Askin framework and how that feeds in. So risk assessment tools, some benefits. Obviously, it raises awareness of risk factors. Minimum standards of risks are assessed. Improved documentation. So through our risk assessment using Purpose T, it's going to feed into our care compass, and it's going to enable us to have tasks such as turning and skin checks on a regular basis based on the risk for our patient. It does mean that it can indicate risk quite easily, making us think of the patient as a holistic patient, and it gives us a framework for care. Obviously, there are limitations around the risk assessments. There is some degree of subjectivity still, and the risk factors that are outlined in Purpose T are not exhaustive, so it's really important that we continue to use our clinical judgment. So how was Purpose T developed? It was created and tested in Leeds NHS Trust. It was based on a systemic evidence and purpose pain cohort study. It involved international interdisciplinary experts in the pressure ulcer field, and it involved pre-testing and field testing with clinical nurses, and it was undertaken in partnership with service users. So the main difference between Purpose T and other widely used tools, will probably be most used to Braden, is that it's got a screening stage for all patients, a full assessment for those who are potential or at risk, saving time in practice. Supports the care planning in response to the patient's risk factors rather than a condensed score. It uses colours to support our decision making. It incorporates not only pressure damage but also the skin status as well, so we're looking at the patient's skin as a whole. It's got a clear distinction between primary and secondary prevention and treatment pathways, i.e. for existing pressure ulcers or scarring from previous pressure ulcers, and it incorporates a minimum data set to facilitate future modelling. This is what it looks like on paper, and this is what we'd be using in downtime, but you'll see the separate sections here from screening, full assessment, our assessment decision, and then the care pathway that you will get either red, amber or green. Pressure ulcer categorization, this is also available in Cerner and you can read through there, but gives you the definitions of different categorization, helping you to categorize our pressure sores for our patients. The Askin framework. So the Askin framework is framework that's used to guide prevention and management of pressure damage or skin damage. So it's important that we assess risk, we look at the skin, we look at the surface, we ensure the patient is keeping moving, we're looking at incontinence and moisture, nutrition and hydration, and then giving information. So the assessment obviously includes our Purpose T assessment, but also thinking about our must assessment. If possible, do your must assessment beforehand, because this will automatically feed into the Purpose T assessment within Cerner. We also want to be thinking about mental capacity. So does our patient have mental capacity to decline our care? So for example, if they are on a red pathway, it's important that we discuss with them what that means, i.e. having to turn them every 2 hours throughout the night, and understand that they understand the risks of that, and make sure if they're declining any other intervention that that's clearly documented. Also thinking about safeguarding in terms of if we find pressure damage on admission, reporting that to safeguarding team, but also to safeguard ourselves as well. Skin inspection, ensuring skin checks are carried out at least once per shift on all patients, ensuring skin checks are carried out more regularly for those that are assessed to be high risk, i.e. on the red pathway would be 2 hourly skin checks, 2 hourly repositioning, and it's really important that we document what we find. So in terms of the skin, what are we looking for? Obviously we've talked about pressure ulcers, but that persistent redness for a category 1, for example, blisters classed as a category 2, but excoriation due to continence issues, discoloration, skin trauma and wounds, we'll be documenting this as a whole within their risk of pressure damage and skin deterioration from other causes. It's important that we identify that early skin damage via the blanching arrhythmia for non-pigmented skin and darkly pigmented skin. This might be that you see it as a purplish blue or darker colour skin tone, that when we press it, it doesn't return to its normal skin tone, and therefore there's early sign of pressure damage. Pressure area hotspots, as you'll see if your patient's lying in bed, you can see those pressure hotspots, but also thinking about when our patient's in the chair, they are still at risk of pressure damage, and that's really important that we recognise that. Surface, we want to be getting all of our patients who are category 2s or above onto an air mattress, and if they've got an air mattress, thinking about the use of an air cushion too. The foam mattresses that we have do have some pressure relieving properties, as you'll see in this left-hand picture. However, it is really important for those patients for category 2 or above. We get the airflow mattresses. As you'll see, they have separate chambers that inflate and deflate to constantly prevent pressure and relieve pressure areas for our patients, even when they are left in one position for 2 hours. We also want to be thinking about our heel boots. This will completely prevent the risk of pressure ulcers on the heels. We've got our Kepra Pro for a protective measure on heels, elbows, etc. as a dressing. And obviously we can use our pillows to elevate heels as well. But what's really important is that if we're using the elevation of use of a pillow to elevate heels, and that's longer for a week, we need to be really thinking about getting our heel boots in place, because this will promote foot drop. We've also got our dolphin therapy beds, which can enable us to use for patients that are really high risk. This will literally alleviate pressure as the patient blinks, for example. It will constantly be relieving pressure. It's really important that we keep our patients repositioning as per their risk assessment, ensuring that 2 or 4 hourly turns are maintained based on that level of risk, and where possible not lying or sitting our patient on a pressure ulcer. If the patient, like we say, is non-consenting to that repositioning regime, we want to ensure that they have capacity and understand the risks of non-compliance, escalate to a nurse in charge. Incontinence, like we said, we need to be thinking about incontinence, so promoting the use of regular toileting, Convenes, PureWicks, catheters at absolutely last resort but may be needed, but also thinking of other things that can relate to moisture associated skin damage like peri-wound, exudate, stomas, etc. Protecting the skin, we want to make sure we're using pH balanced soap, continence aids, like I say, to lock away urine, cleaning skin immediately after incontinence, and that's really important that we identify the risk of incontinence, particularly if our patient is not able to tell us, so that we can make sure we are repositioning them 2 hourly, as that moisture damage can happen really quickly. Please don't use Inco sheets underneath our patients, and not using any oil-based products such as Sudocrem, as this will actually block incontinence pads from being able to absorb moisture. So how do we recognise the difference between pressure ulcer and moisture associated skin damage? Often pressure ulcers are round because they've been exposed to pressure and will be in those pressure points. Moisture associated skin damage is often raggedy edges and will occur where there's moisture, but that's one of the easiest ways to identify that. It's really important that where possible we're also protecting the skin with barrier products. You'll be used to using Cavalon, and this is going to be phased out to use Mediderma barrier film, so it works in exactly the same way, but is what we should be popping on our patients for those that are at risk of pressure and moisture damage. Nutrition and hydration, like we've mentioned, ensuring must is done. Refer to a dietitian as indicated, so this will now be available in Cerner on a red pathway. Fluid and nutrition should be encouraged. We're thinking full fat milk for teas, coffees, etc. Cow shakes, snack packs available from the canteen. It's really important because protein is so important for not only wound healing but for skin health as well. Those patients that are dehydrated, skin will be less elastic and more fragile, therefore more at risk of breakdown. It will also reduce the efficiency of blood circulation, which will impair the supply of oxygen needed for wound healing as well. And as a guide, general fluid intake should be around 1.5 litres a day. So like I've said, it's really important that we are involving our patients in the care pathways. involving them in those conversations around, I've done a risk assessment, it's come out that I need to turn you to hourly, that will mean overnight, is that okay? Getting that consent and making sure we stick to those risk assessments. We can also give our patients advice and information through pressure ulcer prevention, and there will be a link within Cerner for a patient information guide. And one last thing, talking about our wound assessments, if we do find a wound and how we will measure the wound to ensure consistency, we have adopted the use of the clock face, so ensuring that our head is always 12 o'clock and our feet are always 6 o'clock. So imagining a clock face over the wound, and therefore the longest length would always be, well, the longest length it might not be, but the length would always be from 12 till 6, so head to toe, and width the other way, 3 o'clock to 9 o'clock. So place your single-use ruler into the deepest part of the wound to measure the depth if needed as well. And it's really important that we're recording within Cerner in centimetres and millimetres, so for example 7.5 centimetres or 0.8 centimetres. So this is what I mean in terms of imagining that clock face. 12 o'clock is the head, 6 o'clock is the feet, 3 o'clock, 9 o'clock. So our length will be measured always from 12 till 6 and width 3 till 6, even if the width is longer than the length. That ensures consistency, so we can aim to ensure that we are seeing that wound healing and progression.